Good afternoon, everybody in the world, here on the panel, and the organizers of X-Trial, which helped us to set up this wonderful event of an international webinar on hyperproliferative disorders. As an introductory note, I will forward some information about common and different features of benign fibromatosis. This is sent to you from our radiotherapy institution at Osnabrück, Germany. Fibromatosis is considered a fibrous overgrowth of dermal and subcutaneous connective tissue which develops to benign tumors which are called fibromas. They are usually of benign, that means non-cancerous nature. They are characterized only by local growth. Eventually, they can penetrate or push away neighboring structures, but they are not having any metastatic spread. They can be differentiated into superficial and deep, so-called desmoid types. The leading cell type in fibromatosis is a proliferating myofibroblast and fibroblast. They have special genetic dispositions in various disease types, predisposing factors, and unknown trigger mechanisms which are involved in the pathogenesis. You will hear in this webinar biological background as well as clinical situations in which radiotherapy is a worthwhile tool to treat those fibromatosis. First of all, going to the major distributions. Again, we have three different types of fibromatosis: a superficial, so-called fascial type, and a more aggressive, deep located muscular aponeurotic type. In contrast, the malignant fibromatosis would result in a connective tissue malignant growth called fibrosarcoma, which is not dealt in this session. The local defined fibromatosis can occur in skin, subcutaneous tissues, and tendon sheets, while the aggressive type can occur in deeper structures involving muscles, tendons, and visual structures, including organs. The specific diseases which can occur from the superficial facial type are pathologic formation of scars, so-called keloids, palmar, plantar, and penile fibromatosis, other symptoms like frozen shoulders, and other hyperproliferative disorders like heterotopic ossification or Graves' orbitopathy, which are not dealt in this symposium. The aggressive type, deep muscular aponeurotic type fibromatosis, is not dealt in this symposium, but it should be known that it requires much higher doses and is close to a benign but still malignant condition due to growth and compression of vital structures. The different options to treat benign conditions, hypertrophic scars, keloids, palmar, plantar, and penile fibromatosis, can be majorly surgery, but in certain situations also radiotherapy and specific drugs. These pathologic conditions can occur at various time points and in various locations. As you can see here, the right foot is uninvolved, while the left foot has already Lederhost disease, which is currently treated. In addition, the patient has a 2-year follow-up on radiotherapy in the right hand and early signs of Dupuytren in the left hand. There's no rule to which organ starts first or which structure will progress more rapidly than the other. These are the different features we address in this symposium. We will address Dupuytren disease, Garrett's disease, in the pip joints of the hands on the back side. We will address Lederhose disease, keloids in two examples here on the left ear and on the central chest wall, and Peyronie's disease on the penile shaft. All these diseases are characterized that radiotherapy indication is justified by symptom and pain relief, preservation of functional and of improvement chances with giving radiotherapy and surgery or the treatments together. In keloids, cosmesis and aesthetic aspects may play an important role, and also self-esteem and quality of life. Radiotherapy for hypertrophic scars and keloids is always a part of combined treatment approach, mostly in a defined post-operative setting, usually after a first, second, or repeatedly recurrent lesions. Radiotherapy in this instance has to be applied as soon as possible within 24 hours post-surgery. Here you can see the two examples on the helix of the ear and a very awkward long-term keloid pre-treated with various surgical and chemical structures, and in this situation being treated as a primary site without previously applied surgery. Radiotherapy for Peyronie's disease is not supported currently by international guidelines. However, principally useful at early stage, and at this stage there is no functional deficiency and the pathologic process is driven by proliferating fibroblasts and myofibroblasts. However, there are numerous numbers of studies where it has been historically used in more advanced stages for pain relief, improvement or stabilization of penile deviation and functional status. Here you see some basic setups of the radiation therapy technique, like the lead cover to protect the gonads and the electron beam cone to address the shaft of the penis. In Dupuytren and Lederhose and Garrett's disease, which resembles the knuckle pads, the primary prophylactic radiotherapy is the major indication. It is usually used in the early stage where only nodules and cords are present. In some situations, radiotherapy may be used as a post-interventional device after needle fasciectomy, collagenase injection, or limited open fasciectomy. It is also considered to be optional as a salvage radiotherapy after relapses, either after surgery or radiotherapy. However, most important, the majority of cases will never require radiotherapy and has to be followed by defined wait-and-see strategies. Regarding the clinical concepts used for the 4 different indications we address in this symposium, there are 3 major concepts. First of all, the prophylactic early stage radiotherapy, where Dupuytren and Lederhose patients have not been operated, but the early intervention allows to prevent surgery at all or delay the whole treatment process for years or decades. In this instance, 2 series of each 5 × 3 gray with a 3-month gap are applied. Usually, it is indicated to provide radiotherapy if a 3 to 6 months proven progress has been shown. In Peyronie's disease, prophylactic radiotherapy is rare. It's only indicated for early cases. Usually, only 1 RT series is given 5 to 7 times 3 gray. Again, the indication should only be given if a proven progress of a certain period of time has been addressed. Keloids cannot be treated prophylactically. However, they are treated post-operatively after resection of keloids which have not responded to surgery or other local measures alone. So the secondary indication would be a post-interventional radiotherapy option, which is scientifically not proven for certain Dupuytren and Ledderhose indications. It can be symptomatic for peyronie disease to relieve pain, and it can be adjuvant to surgery or symptomatic radiotherapy if no surgery performed. With regard to radiation therapy techniques, there are 3 different options available. In Dupuytren and Ledderhose, usually orthovoltage X-rays are applied with 50 kV to up to 200 kV in deeper structures like Ledderhose disease. Usually no bolus material is applied, and lead rubber plates are used to protect uninvolved areas from radiation. In addition, in recent times, linear electrons have been used with 3 to 9 MeV energies using lead cutouts due to the higher energy with 2 centimeter lead cutouts. In Peyronie's disease, reports exist about the use of orthovoltage and linear electrons, while in keloids also techniques using brachytherapy have been described in the literature. Important is today to integrate CT and MRT imaging into 3D radiotherapy planning. As with these imaging techniques, it is better possible to recognize the active disease and to individualize the radiotherapy planning to better target or protect structures. On the left side, the anatomical structure of the palmar aponeurosis is shown, while the hypotenar and tenar muscles are never involved with Dupuytren, as well as never the distal regions of the fingers. So fingernails and muscle areas should be protected from radiation. Also, very rarely, Dupuytren involves the hand-wrist area. So the marked area is usually the area where 95% of Dupuytren disease can occur, with some possible involvement of fingers up to the dip joint. On the middle graph, you can see a typical example of a man with an involvement bilateral, with the left hand being involved with the thumb to the small finger, so D1 to D5 area, while the right hand is only involved from D5 to D2, and the thumb is uninvolved. Typically, a field of 10 or 12 centimeter length and with an angulation of about 60 degrees will be sufficient to cover the D2 to D5 area, avoiding the wrist, avoiding the muscles, and avoiding the distal segments of the finger. On the other hand, planning for Ledderhose disease can show more involvement in MRI images due to perfusional changes. Professor Wolfson will present in this webinar his results for prognostic planning. The chance of using CT and MRI fusion provides us with the option to better individualize our treatment instead of doing rectangular fields for probability presentations. Again, looking at the different techniques, the question now arises, are these techniques equal and do they provide equal results? If they are properly applied, usually these techniques should present us with similar clinical results. However, the setup appears much more simple in the orthovoltage setting, with a cone being mechanically put down on the foot, while here a whole table and a whole machine has to be moved and approached. So setup usually takes a little bit longer time on the linear accelerator than in the orthovolt machine. Here you can see the different depths, isodose depth curves for different energies. And with regard to electrons and orthovolt energies, the depth structures are pretty similar, with some differences in the first 1 to 2 centimeters, with some lower doses at the surface for electrons and with higher doses at some other depth structures. So usually the compensation is possible with adding additional bolus material of 5 to 10 millimeters to shape the penetration depth in electrons, while in orthovoltage only the energy can be raised to get deeper penetration. Here you can see that with both techniques like orthovoltage, 4 centimeter penetration depth can be reached with 200 kV, while it can also be reached with electrons. So penetration depth up to 4 centimeters can be equally physically and clinically provided to any patient with superficial fibromatosis, benign fibromatosis. And so if correctly applied, no differences should be seen when we compare electrons versus orthovolt X-rays. However, the costs are significant. The usual machine, orthovoltage machine, is a tenth of the price we have to pay for a linear accelerators. However, this machine is usually used in a much higher range of indications. In terms of clinical evidence and state of the art of radiotherapy, a comparison of PubMed clinical studies for Lederhose in the 50-year area from 1970 to 2020 provides results from 17 studies. For Dupuytren in the same period, 117 studies. For Peyronie's disease, 80 studies, and to a big surprise, keloids, far more than 500 studies. So the evidence actually should be best in keloids. However, no randomized studies have been provided here. Randomized studies are ongoing now in Australia. Martin Gerard will report about it, and in the Netherlands regarding Lederhose disease. And Dr. Stenbergers will tell us about his results. In Germany, in 1996, a quasi-randomized study was started with a control group compared with a randomized group of 21 to 30 grade, which was published in 2001. A long-term outcome trial has been provided by Erlangen, Essen, and Offenbach clinics, and there are numerous phase 1-2 trials. Peyronie's and keloids have no controlled randomized studies and no double-blind randomized studies. However, some few large areas, for example from Rotterdam, Netherlands, and many large series for keloids have been performed in the past. So clinical evidence would be difficult to prove with a randomized study, while evidence has grown already in these indications. So coming to an evaluation of the level of evidence, due to the lack of randomized studies, usually keloids and hypertrophic scars, the evidence for radiotherapy is in the level of 2B, Peyronie's 2 to 3, B to C, Dupuytren and Lederhose in the level of 2 to 3, B and C. In terms of our probability to see those patients in Germany, we can look for the DECRO Petals of Scare study, which looked into the number of patients being treated in Germany, and about 40% of the institutions submitted their data of about 36,000 patients, generalizing that about 100,000 patients are treated in Germany for non-malignant disorders. And of those 4%, which would mean about 4,000 patients may be treated for hyperproliferative disorders, with the majority being Dupuytren disease, Lederhose disease, keloids, and other disorders. So from these frequencies, we can expect that the probability to have those treatments in Europe and worldwide should be in the thousands, and it is worthwhile to look for new evidence to bring these indications forward to other societies and to other areas in the world. Thank you very much.
Thank you, Dr. Seegenschmiedt. Okay, Dr. Seegenschmiedt, the first question is around Dupuytren's and Lederhosen. Do you sometimes omit the second course of treatment, and why?
Very interesting. COVID-19 has made it necessary to omit radiation, sometimes for 9 to 12 months. And it was interesting to see that the first progressions in some patients occurred after 6 months. So probably it is possible to have the second series even later than 3 months. However, in our experience in Essen and in other sites in Hamburg was clearly that about 40 to 50% of patients with only one series will require a second series due to progression. So it is not recommended to avoid the second series.
Okay, thank you. Next question is around what role do you see for MV photons?
Usually, Dupuytren is treated by 6 MV photons. We have the lead cutouts, which have a thickness of about 2 centimeters, and we are sometimes using 5 or 10 millimeter bolus to adapt the penetration depths. When you do CT scanning of the hand, you see that only about 1/3 of the thickness of the hand in the central part of the hand needs to be irradiated. So we want to avoid as much dose to the backside of the hand.
Okay, next question. We have time for a couple more questions because we have a very full agenda today. So two more questions. For those of you who have submitted questions that we won't be able to answer, we'll make sure to connect you to Dr. Seegenschmiedt offline. Next question is, what is your referral pattern? Who refers to you for benign radiotherapy, and how do you provide follow-up back to the referring team?
Usually referrals are to my practice and to Osnabrück nationwide and even international wide. Mostly 1/3 to 1/2 of the patient will not be treated right away, but will be followed up until we see progression. And if we treat, we usually treat within 3 to 4 months a second series, and after that, after 3 months and 12 months, we do a 3 months early evaluation and a 12 months late evaluation. And from then on, we can do the email follow-up with follow-up forms which are sent to the patient and sent back. Or we even offer video consultation to patients if they request this, just for first evaluation.
Okay, great. Final question. You mentioned Garrett's disease, but didn't mention its treatment. Is it the same as with Dupuytren's with the 2 series of 5x3 gray, or is there another treatment for it?
My experience over 25 years with Garrett's disease is not very successful. Overall, the procedure nowadays would be to treat only Garrett's disease nodules which are painful, are symptomatic. We then give just 1 series and observe if they do respond. A response would be just pain release, but not size reduction. And in some other cases, we ask patients to get the nodules removed and then do post-op radiotherapy, just 1 series. We will not give 2 series to have the option to treat a second time later in the lifeline.
Okay, thank you. And again, thank you, Dr. Seegenschmiedt, for chairing this section of our conference. We really are grateful for your participation and for organizing this great group of speakers today.